welcome to our webinar this evening. For those who don't know me, my name is Jess and I am part of the PKD Australia team, and I'll be your host this evening. I'd like to begin by acknowledging the traditional owners of the various lands on which we meet today, and I would also like to pay my respects to elders past, present, and emerging. Leading the presentation this evening is Professor Edwin Kirk, and Professor Edwin is a clinical geneticist at Sydney Children's Hospital and a genetic pathologist at New South Wales Health Pathology's Randwick Genomics Laboratory. And he co-led the Mackenzie Mission Carrier Screening Project, which was a 3-year research study that ended in 2022, which we will hear more about this evening. Tonight's webinar is about genetic carrier screening and family planning. So, Professor Edwin, over to you.
Thanks very much. Okay, I will now attempt to share my screen with the usual mixed results, no doubt. There we go. And so, is that working? Is that in the presentation mode?
We're up.
How about that? First go. All right, yeah, so I'm Edwin, and I'm speaking about reproductive genetic carrier screening and a bit about Mackenzie's mission. I'll just start with a rather large acknowledgement slide because Mackenzie's mission involved over 1,000 people in one way or another, and some of the people who contributed most are listed on this slide, and the organisations as well. So I'm going to be talking a bit about autosomal recessive and X-linked inheritance, about carrier screening itself, what it's for and how it can be done, the options for couples who are found to have a high chance, or some people talk about high risk of having a child affected by one of the conditions that are screened for. A bit about the history of carrier screening and about Mackenzie's mission, and then where we're at in Australia. So this is high school genetics, and some of it may be quite familiar to you, but I'll just start with this. So this is a figure illustrating autosomal recessive inheritance. And the basic idea is that a gene is like a set of instructions to the cells of the body to do a particular task. And they come in pairs. The sex chromosomes are a special case that I'll get onto in a moment. And you get one of your pair of any one gene from your mum and one from your dad. And in this situation, both partners are carriers, there's the little r, for a change in a gene, the same gene. And it has to be the same gene. And if a child inherits both of the faulty copies, then they're affected by the condition. If they inherit one healthy functioning copy and one faulty copy, then they're a carrier like their parents. And if they inherit both of the normal copies, then they're neither a carrier nor affected. So being a carrier usually causes you no health problems, so you don't usually know about it. And carrier couples usually only find out when an affected child is born, and then they learn about that 1 in 4 chance. For X-linked conditions, women have 2 X chromosomes, men have an X and a Y, and girls who have 1 X chromosome with a change in a gene, a disease-associated gene, may have some features of the condition, or they may be unaffected, and it depends on lots of different factors. And boys will usually be affected. There are some special cases. So a 1 in 4 chance of an affected male child, who would usually be more severely affected than a female child who's carrying the faulty copy of the gene, but she may also have significant problems. So those are autosomal recessive and X-linked inheritance. And you may well ask, what about autosomal dominant conditions? And these are not included in genetic carrier screening, because the idea is to pick up people who wouldn't have had another way of finding out that they were carriers. And so, for example, PKD1 and PK2 are not included in any carrier screening test. And all of the questions I've received in advance of the talk are about PKD1 and PKD2 genetic testing. And I'll do my best to tackle related topics. I'll do my best to tackle those. But the reason why carrier screening is still relevant is that having one genetic condition does not make you immune from having a child affected by a different genetic condition. And we certainly do see families in which there are 2 or even more genetic conditions. And so this is something for anyone who is considering having a child to think about and to be aware of. So I've talked a bit about these. There are about 2,500 more now, actually, genes linked to these types of inheritance. The majority of those are autosomal recessive. It's estimated that each of us carries perhaps about 2 severe recessive variants or genetic changes associated with a recessive condition. Although an occasional person might not carry any, and some people carry quite a lot. It's randomly distributed. And with some rare exceptions, being a carrier for recessive condition, as I said, is harmless, whereas that may not be true for all X-linked conditions. And it's really important to understand that most carriers only find out when a child is born. That's the whole impetus behind doing screening, is to give people information before they have an affected child, because we know that when there is a severe condition, most couples who know their carrier status do take action to avoid having an affected child. And I'll talk about what the various possible actions are. And we're talking about a really wide variety of conditions, all body systems, all age groups. Our particular focus is on severe childhood conditions, and many of them are severe and are life-limiting or disabling or both. Some examples of conditions you may have heard of include cystic fibrosis, spinal muscular atrophy, which are both autosomal recessive conditions, and Duchenne muscular dystrophy and Fragile X syndrome, which are X-linked conditions. And these are individually rare. So a common condition in this group would be cystic fibrosis, which affects about 1 in 2,500 babies. But because there are so many conditions, collectively they're not rare, and they have a large impact on families in Australia and, of course, on the health system. So the idea of carrier screening, as I've said, is to identify couples before they have an affected child. And it can be done before or early in pregnancy, but before is much better because it gives you time to deal with the result and make decisions. You're not under time pressure as you would be if there were an ongoing pregnancy already. And it also allows some options that aren't available if there's already a pregnancy. We think about the purpose of carrier screening as giving couples reproductive autonomy. In other words, giving them control over decision making about reproductive decision making in relation to a genetic condition. And they wouldn't have that reproductive autonomy without the information. And then, of course, to allow them to make informed decisions in accordance with their values. And that will mean different things for different people in relation to different conditions. And it's certainly not something that we want to dictate what people should do with the information. Just because information is available doesn't mean you have to take any particular course in relation to it. And other goals, such as preventing suffering, clearly are important and are things that we think about, but in the field are considered really to be secondary to that idea of giving people autonomy. There are a couple of different ways that we do this. So one of those is sequential testing, and that's where you test one partner, almost always the female partner first. And I just want to acknowledge that not everyone is in a traditional male and female relationship, and we're talking really about the reproductive partner, so who provides the egg and the sperm. And that'll apply to everything I'm saying here. So we test the female partner first, only test the male if the female partner is found to be a carrier for an autosomal recessive condition. So the advantage of that approach is that it's less expensive. The main disadvantage is that it takes longer, and also that if you're testing for a lot of genes, there's quite a high chance that you'll find carrier status for at least one condition in the first person you test, and so then you have that information and you go on and have to test the other partner. In couple screening, you test both people at the same time, and that's obviously more expensive because you're doing twice as much testing, but it's quicker and you get fully interpretable information right from the word go. And sometimes the only reported information is information that results in a high chance of having an affected child, and sometimes individual carrier results are provided. That depends on the laboratory that's doing the test. So what does it look like in practice? Well, someone who's planning a pregnancy, hopefully, or already is pregnant, decide to have screening, consider the options, and I'll give you a website towards the end that provides a lot of options for different tests. Then have the test, and that might be a mouth swab, and there's the picture there of the typical kind of swabs that we use, or a blood test, and that'll depend on the circumstances. And then results are received, and most couples will get reassuring information. But if it's not, then that will typically lead to a discussion with a genetic counsellor, perhaps with a clinical geneticist, and maybe other relevant healthcare professionals. For example, a kidney specialist if it's a kidney condition that's been identified. And then the couple can consider their options. So what are their options? Well, if there's an ongoing pregnancy already, then the choice they face is really whether to have prenatal diagnosis or not. And that includes CVS or amniocentesis, and I'll explain a bit more about those for those who may not be familiar with them. Whereas before pregnancy, the options are a bit broader. So you can choose not to have children or to have more children if you already have children, or to adopt, or to use donor egg or sperm. Donor sperm is not an option for an X-linked condition. Because the potential problem would be with a gene that would be passed through the egg, or to do in vitro fertilization and pre-implantation genetic testing. So that's where the embryo is tested at a few days and only an unaffected embryo is implanted, or natural conception followed by prenatal diagnosis, or conception by any means and prenatal diagnosis, or lastly, no intervention, which is to take the chance of having an affected child and accept that that may happen. So this is chorionic villus sampling. The idea is that the placenta shares its genetic makeup with the fetus, and typically at around 11 to 12 weeks, the test is done under ultrasound guidance, and the picture on the left shows the most common way of doing that, which is a needle that's passed through the woman's abdomen, and a small sample of the placenta is taken, and then that's used for testing. There is another method that's sometimes used, particularly if the placenta is lying in an awkward position for the needle, which involves a flexible tube that gets passed through the cervix and behind the membranes. And this procedure is generally very safe. It's associated with a small risk of causing a miscarriage, and it is done at a time of pregnancy when some miscarriages are still happening naturally. I mean, miscarriages can happen or pregnancy loss throughout the pregnancy, but more common early, and it's still in a period of relatively high risk, although it falls as the pregnancy progresses. But there is a small chance, and we typically say less than 1% of causing a miscarriage from the procedure. There's a bit of controversy about exactly how high that risk is, by the way. Amniocentesis is done a bit later. 15 weeks, as it says in the text at the top there, would be quite early. This, by the way, these images are from the Centre for Genetics Education, and there are information sheets available on the genetics.edu.au website. And there are cells from the fetus floating in the amniotic fluid, and so a sample is taken and the DNA is extracted from that, and the testing is done using that. And again, there's a small risk of miscarriage. Traditionally has been said to be lower than the risk from CVS, although the evidence for that, it's a bit tricky because you can't set up a test where you randomly give 1,000 women a CVS and 1,000 women amniocentesis and see what the outcomes are. But people do talk about this being slightly less risky. And then PGD, or these days it's called PGT, pre-implantation genetic testing, where the embryo is allowed to grow for a few days, then a few cells are taken out, and there's genetic testing, and an embryo is selected that doesn't have the genetic change that leads to the condition, and that's transferred. Okay, a bit of a pace now. I'm going to take a bit of change of pace now. I'm going to take you back to Cyprus in the 1970s. And I don't know how much time you spend thinking about Cyprus in the 1970s, but on the remote chance that you do, I think this is probably the image you might have in your head. Sun, sand, I guess Retsina. I haven't been to Cyprus, and that might be the extent of it. But when I think of Cyprus in the 1970s, I think about this, and this is a blood film. And it's from someone who has thalassemia, and you can see the red blood cells are all different shapes and sizes, and a lot of them are very pale. You have to take my word for that if you're not familiar with looking at blood films, and this isn't the best picture, to be honest, but this is a condition called beta thalassemia, and people who are affected by this condition have fragile red blood cells, and they develop severe anemia early in life, and typically need repeated blood transfusions to allow them to grow and be healthy. And there are all sorts of complications that can go along with that. And it's obviously quite burdensome having to have frequent blood transfusions. And in why Cyprus? So an enormous proportion of the population were carriers for one form or another of beta thalassemia. And at the time that screening was started, nearly 1% of babies that were born were affected by the condition. And in 1978, 45% of the output of the Nicosia blood bank, the capital of Cyprus, was being used for treating thalassemia, which is an extraordinary amount, and 6% was being used for a drug that's used to treat the iron overload that comes with repeated blood transfusions, 6% of the budget of the Ministry of Health. So it was a very important health condition for Cyprus. And the idea of carrier screening actually goes back as far as 1955, so it's not a particularly new idea. And so Ida Bianco and Enzo Silvestroni suggest the possibility of what they called preventative counselling. And we don't really talk about prevention so much these days, but that was the way it was thought about. And Professor George Stamatianopoulos, who later became a major figure in gene therapy, went to a particular village in Greece where there was an exceptionally high frequency of actually sickle cell disease, another related condition. And he tested the whole population and counseled carriers against marrying one another. When he came back a year later, he found that this had precisely zero impact. But nonetheless, the experience was helpful, and he was asked by the World Health Organization to visit Cyprus and consider the option of a screening program. And within a few years, the screening program commenced. And this is a table from a publication in The Lancet, which is a medical journal you may have heard of, showing the total births in Cyprus over the years 1974 to 1979, and they were growing steadily. And based on that, the expected number of children born with thalassemia, and then the actual numbers, which in fact, instead of rising, fell steadily. And that reflected a large uptake in the community and people taking steps, even though the options were much more limited in those days, to avoid having affected children. In Australia, there has been screening in an ad hoc way for thalassemia for a long time, but one of the things that Australia has been quite active in is screening for a group of conditions that are more common in people of Ashkenazi Jewish heritage, and particularly a condition called Tay-Sachs disease, which is a neurodegenerative condition that affects quite small children. And testing began back in 1995, first in Sydney, then in Melbourne, initially using not a DNA-based method, but a method that involved directly testing the enzyme that was deficient in this condition. And the testing was expanded over the years and also includes cystic fibrosis, which is relatively common in people of Ashkenazi Jewish heritage, but also in people from European backgrounds generally. And the impact of that is that no child affected by, one of the impacts of that is that no child affected by Tay-Sachs disease has been born to parents who had had screening since the program began. And also the program has been shown to be cost effective. And again, it's not about saving money, but if you can't show that it's achievable with reasonable health budgets, then there's no way to get a health department or a government to consider funding it. So it is important for us to study that. So this thing that looks like a washing machine is not a washing machine. It's a NovaSeq 6000, and it's one of a number of different machines that are used for genetic sequencing. This is made by one of the leading companies, Illumina. And the slide's there because the reason that we're talking about carrier screening is that the advances in technology have meant that it is increasingly possible to do sequencing, so read the sequence of large numbers of genes all in one test at a relatively low cost. And this is a bit of an old slide now, but it shows a rapid decline in the cost of doing whole genome sequencing in this case. This is nearly the cost of whole genome sequencing. So from $100,000 in 2000 to more like $1 per gigabase in the sort of recent past. And that means that it's now possible and practicable to screen for hundreds or even more than 1,000 genes in a single test. And the reason why that's important is that there are a very large number, as I said earlier, of different genetic conditions that we might want to screen for. So then the question becomes, which genes should we screen for? And we don't screen for all 2,500, and there are various reasons for that. One is that there are technical and cost limitations, particularly technical, so some genes are quite hard to screen for. And then we have to think about which conditions are the most important for screening. So, for example, there is an autosomal recessive condition called uncombable hair. And while that may be a nuisance, it's not what we would consider a severe condition because the people are otherwise completely healthy. And so nobody really includes that in carrier screening, whereas there are other severe conditions that are pretty much in all the different panels of genes that are used. And so different groups and companies have come up with different answers about what should be screened for, and there really isn't one right answer. And typically, a lot of the more common severe conditions will be included in most panels, although there is surprisingly little overlap that's included in every panel that's out there. So that term panel of genes really refers to a group of genes that are included in a single test. Now, if you do have screening, it's important to understand that no test is perfect. So a negative or low chance result reduces the chance you could have a child affected by a genetic condition, but it doesn't completely rule it out, including for the genes that are included in the test. So the limitations of current testing include that not all of the genes are included in every test, and some of them are much more limited than others. There are some types of genetic change that are just not detectable by the methods we're currently using. And we're limited by our knowledge because labs generally report changes in genes that we are confident will cause a genetic condition, either by itself in an X-linked condition or when combined with another pathogenic variant in an autosomal recessive condition. And that means that the lab might find a genetic change, but not know if it can cause disease and thus not report it because of the risk of doing harm by wrongly creating the impression that there's a risk where there really isn't. All right, I'm going to talk a bit about Mackenzie's mission now. So there had been research going on for some time when there was kind of a confluence of events. So sadly, Mackenzie Casella, who's the little girl in the picture there, pictured with her parents, Rachel and Johnny, died aged 7 months from a neurological condition that I've mentioned briefly before called spinal muscular atrophy. That was back in 2017. And they had done their best to prepare for pregnancy, but hadn't been told about carrier screening and didn't find out about it. And they learned that it was possible, and they became powerful advocates for carrier screening. And they lobbied the federal government and met with the then Health Minister, Greg Hunt. And as it happened, a group of us researchers had been in contact with the health department to talk about the possibility of a pilot project. And because of the advocacy of Rachel and Johnny, Minister Hunt engaged with that, and a large national research project funded by the Medical Research Future Fund was launched, and that was called Mackenzie's Mission in honour of Mackenzie Casella. And the aims were to assess the acceptability and feasibility of an accessible carrier screening program in Australia. So the long-term goal really is to make carrier screening widely available for anyone in Australia, any couple in Australia who wish to access it. And we initially aimed to screen 10,000 couples, but the pandemic squashed our ambitions somewhat. For carrier status, what in the end wound up being nearly 1,300, or initially 1,300, and then a slightly smaller number, autosomal recessive and X-linked genes associated with those types of inheritance before or early in pregnancy. And we studied all sorts of different aspects of carrier screening with the idea that we would have all the information that was needed to make the case for and set up a national program. And we're still working on that, even though the major part of the project is completed. And underpinning everything was ethical considerations and bioethical analysis. So the gene selection, I talked a little bit about gene selection. The overarching principle is the condition should be one for which the average couple, whoever they might be, would take action to prevent having a child with that condition, and or where early diagnosis can improve prognosis. And we had a committee that involved a number of different people from various disciplines, and also Rachel Casella herself, as well as our ethicists. And we started with 1,300, well, we wound up with 1,300 genes, which is what we started screening for. For various reasons, we took some out and added a few in, and we wound up with a number of 1,281. And as I mentioned, we did not report variants if we were uncertain about their clinical significance, and also tried to limit reporting to conditions that would have met our original criteria for inclusion. So the variant combination would have a severe presentation in a child. We did include a number of genes related to kidney disease, including PKHD1, which is associated with autosomal recessive polycystic kidney disease, and various others for conditions including Alport syndrome, Bartter syndrome, nephrotic syndrome, the childhood types. About 40 genes associated with conditions that are mainly affecting the kidney, and these are mostly autosomal recessive, although X-linked Alport syndrome was an important X-linked example. So we used a couple model, so we screened both partners at the same time, and we issued either a low chance result, so we didn't issue individual carrier information except for X-linked conditions, or an increased chance result if both were carriers for the same autosomal recessive condition or the female partner was a carrier for an X-linked condition. We recruited people through their healthcare providers, and we educated those people in the project. And there were over 1,000 who came on board. Not all of them wound up recruiting people to the study. And we wanted them to be representative of the provision of pre-pregnancy and early pregnancy healthcare in Australia. So GPs, obstetricians, midwives, and fertility and genetic specialists. And we really wanted to mirror how women and couples access that kind of care. One of the consequences of the pandemic was the GPs really had their hands full, and so we had more recruitment through specialists than we had originally intended. But there still were more than 3,000 couples recruited through general practitioners. And we also wanted to achieve a sample that was as representative as possible of the Australian population. People, once they were given brief information and a leaflet and a unique enrolment number by their healthcare provider, went online and they were given information via our website. Each partner had to go to the website, receive education. They could complete a decision aid about having screening. There were research surveys and then a consent process online. And if they went through all that and consented, we posted out a mouth swab kit. And that was also fortunate from a pandemic point of view because it was something that could continue even when a lot of things were closed and people weren't able to leave their homes. And we did make efforts to make things accessible for those who might not be able to just log on to an English language website and use the standard pathway. So we had just over 10,000 couples who logged on at least once. And we estimated that represented nearly half of the people who were offered participation in the study. And we think that if this were a national program, the uptake would be much higher than that because it really did involve being willing to take part in a research project. Not everyone wants to do that or has time to. Of the 10,000, 783 didn't complete the enrolment process. Only 5 went all the way through and then declined. So there were 143 who didn't return their kits, even though they'd gone through all the process and we'd sent them out the kit and some reminders. And that meant that just over 9,000 couples actually went through screening. And they were distributed much like the population of Australia. And oops, sorry, I've just lost my. Oh, there we go. And they were reasonably representative of the socio-economic demographics, a bit more educated and a bit better off than the population as a whole, which I guess may reflect the people who are likely to be information rich. But nonetheless, we had sufficient people from all of the large groupings to analyse the data successfully. What do we find? So 96% had a low chance result. About 2% were already known to be carriers. And again, that relates to the fact that a lot of our recruitment was through genetic specialists and other healthcare professionals who are more likely to be seeing couples with a known history. And there were 151 new increased chance findings, which worked out at being just under 2%. And that's probably a somewhat high number. Oh, by the way, there were also 4 couples who already knew they were carrier for one condition and found that they were carriers for a second condition. When we look at recruitment through general practitioners, it was lower, it's like 1.3%. And for various reasons, we think that at population scale, it may be a little lower still. So perhaps at or slightly above 1%. For couples where the partners are related to one another, typically as first cousins, because you share genetic makeup with your relatives, if you're a carrier, your partner, if they're a cousin, is more likely to be a carrier as well. And so not surprisingly, the pickup rate was much higher, about 18%. And that reflects experience in other parts of the world as well. I talked about the limitations of testing earlier. So of those that were known to be carriers, 84% we would have been able to detect and report that. And of the 28 that we wouldn't have been able to, a decent chunk of those were for technical reasons. So that stands for copy number variant. So types of genetic change that wasn't well detected by or detected at all by the test we were using. And 18, one that had both, but were due to variant classification, meaning that there wasn't enough information available in the absence of an affected child for us to work out that a particular genetic change was going to cause disease. A little bit about what people did with the information. So of those, and I'm just got, there's a lot of different slides and I've just selected a few. So for those who were not pregnant at the time of results, just over 80% made a choice to avoid the condition. At the time of the survey, there were 12% who were still deciding, and just 7% had made a choice not to avoid the condition. And of those who chose to avoid the condition, 83% chose pre-implantation genetic testing. And I don't think I mentioned that as part of the study, we provided one funded round of pre-implantation genetic testing. So this really reflects what people do when cost is not a consideration. And that's out of date. We've had rather more than that now. So overall, 83% have chosen some reproductive intervention to avoid the genetic condition in their child. When people have screening before there's a pregnancy, the uptake is of prenatal diagnosis, so conception, testing the pregnant and ongoing pregnancy is much lower, and most choose PGT when that's an option for them. And obviously this is a selected group who've undergone screening themselves, but 96% felt carrier screening should be available to all couples in Australia. I kind of wish we could talk to the 4%. 95% thought it should be available free of charge. This should be something the government ought to provide. And the fact that we offered screening at no charge for some of them was a motivating factor in the decision to take part. And the great majority were glad to have the information available when they were planning a pregnancy. All right, so that's a bit about Mackenzie's mission, and I'm just going to talk a bit now about the current state of genetic carrier screening in Australia. So where we're at the moment is that there is government-funded screening since November last year for screening for cystic fibrosis, spinal muscular atrophy, and Fragile X syndrome. And the model that's being used is sequential screening, where the female partner is screened first, and only if she's a carrier for CF or spinal muscular atrophy is the male partner screened. And the 3 genes actually count for 20% of everything we found looking at nearly 1,300 genes. And you can look at that in 2 ways. I think you can say, well, wow, 3 genes gets you as much as a fifth of 1,300 genes, or you could consider that you're leaving 80% of what might be achieved on the table. And I think they're both valid points of view. So we've been talking, you may hear this term expanded carrier screening. We're talking about screening for large numbers of genes, and that is available in Australia at the moment. It's mainly available through commercial laboratories, and all of those, it's a user pays basis. And we are still making efforts to provide all the evidence that the government requires to fund a national program. This will be a very expensive undertaking, a major change to healthcare. So we're not surprised that our initial application for funding wasn't successful, although it was well received. And the government asked us for further information, some of which we'd already collected during the project and some which we had not. So there's a little bit of fill-in work being done to answer some of the questions that they've got for us. The tests that are available at the moment vary quite a bit in terms of the number and nature of genes, and I've kind of mentioned that already. Most commonly, it's sequential screening, but there are providers that offer couple-based screening. And I've talked about the fact that if you do sequential screening with a large panel of genes, there's a high chance the female partner will be a carrier for at least one. And in an Australian-based test, the cost may be partly offset by Medicare funding for the 3-gene screen. Labs that are overseas can't bill Medicare. So where to from here? So the 3-gene screening actually is a pretty major step. So we're the second country in the world, to my knowledge, to have any public funding for reproductive carrier screening. The first was Israel, which has been doing it for quite a long time. It was an opportunity, it gives us the opportunity to see how large-scale screening fares in the real world. And there are thousands and thousands of people taking up this option of these 3 genes. One of the things is, because this was funded as a Medicare item, it really was only the test, and there wasn't any support and not a great deal of planning for the pre-test considerations. Although, to be fair, the laboratories that are offering it do generally have good websites that give you information about the test and what to expect. But also support for referrers. Again, laboratories have done a pretty good job at that. Laboratory capacity, and it has been, I think, hard work for the labs that are offering this. And then the post-test issues, so counselling, some of which is provided by the labs, and then prenatal diagnosis and PGT. So it is a big deal that we have screening for the 3 genes available, but there certainly is more to be done. So in summary, almost everyone's a carrier for one or more genetic conditions, and that's usually only a problem if we have a child with a partner who's also a carrier for a change in exactly the same gene, or if a woman is a carrier for an X-linked condition. Most people don't know they're carriers until they have an affected child. So people sometimes think that this relates to whether they have a family history or not, but really I think it's an important message that it's not about whether you've got a family history, although that of course might be important information for that particular condition. But really it's something that is relevant to everybody. And screening does have the potential to provide information before an affected child is born and allow the couple to make informed decisions. It's very much a choice, and clearly it's not something for everyone for all sorts of reasons. And as I mentioned, there's a website, I've misspelled that slightly, carrier screening with only one n.org.au. Sorry, I've left the I out. That's what's wrong with it. Carrierscreening.org.au. And they haven't included everything, including, interestingly, a test that's associated with the group that put together. So I imagine they'll probably add that soon. I wrote to them when I noticed. So at that point, I'll stop sharing. And what would you like me to do? There was a question that came up during the talk. Shall I tackle that one first, or do you want me to go to the questions?
Yeah, let's do that. Let's answer that question from Kevin.
Does screening have a negative effect for future financial needs, such as causing issues or loading with getting insurance? The chance of that is very small. As I mentioned, generally speaking, being a carrier for an autosomal recessive condition is not relevant for your health, although there are some rare exceptions. But there is some chance, and that was certainly something that information that we include in the pre-test information for Mackenzie's mission, that you might receive information that's relevant for your own health. And that particularly relates to X-linked conditions. And in fact, X-linked Allport syndrome, which is a kidney condition, is an example of that, where female carriers for X-linked Allport, can themselves have sometimes significant kidney issues. So there is a small chance that undergoing screening might yield information that could be relevant. And then as to whether that would affect your ability to get insurance, for life insurance, the Australian insurance industry has a voluntary moratorium on discriminating against people for life insurance for policies up to $500,000 on the basis of genetic information. There is quite a strong push on at the moment to have legislation enacted that would prevent genetic discrimination in insurance. And I very much hope that gets up. And
I'll jump in there and just let our community know that PKD Australia has actually submitted, as part of that submission to the government, to do exactly that. So continue.
That's very good to hear. But there is I mean, clearly it doesn't apply at all for policies over 500,000, and it is still a voluntary thing. There is also the potential that some other types of insurance, such as income protection insurance, could be affected. So it's not a high chance that that kind of outcome could happen, but it's not zero. And if you were considering having screening and were also considering taking out insurance, it might be a good idea to, if you've got time and there's not an ongoing pregnancy already, to tackle the insurance before you underwent screening. Because once there's an existing policy, my understanding is that you're not at risk of that being affected by any information that you didn't have at the time that you took out the policy.
Great. We have another question that's just come through from Andrea.
Mm-hmm.
And that one's in the Q&A bubble.
Oh.
She says, I have AD PKD. My daughter is 8. Would it be worth me getting genetic testing to see if I carry the mutant gene?
Oh, so so this is someone who hasn't already had testing. Yeah, so I mean, this is actually a bit, I guess, in terms the thinking there is in terms of them potentially testing the daughter. I assume, and it's actually a somewhat controversial topic, but I think the general feeling is that so because getting information that may tell you future information about your child can have potential negative as well as positive impacts. And that's quite a large and complex topic that I can fully deal with here. But it would be something that's quite reasonable to talk to a genetic service about. And children are sometimes tested for the risk for adult or largely adult conditions in consultation with a genetic counselor and often a clinical geneticist. So it's not an unreasonable thought, and some people do pursue that. But you do need to be aware that it's something that has complexities, and it's not entirely black and white as to whether that's something that you should do.
Thank you. And another reminder, we actually spoke with KidGen a couple months ago on genetic counts. They were genetic counselors. And so if you're looking for information on that, feel free to jump on our YouTube channel and you can see more about that as well. Are there any other questions?
They really are. The KidGen group are very much the experts on that topic.
Chirag and Caitlin, they were wonderful.
Yeah. And I should say I haven't prepared extensively for all the questions that came through about PKD because I only really saw them today, and it wasn't kind of the focus of the talk. But I can do my best. Would you like me to tackle
yes,
the
if
questions
there's
that came through?
Yep.
All right. Okay, so one of them I think we've just tackled. In fact, so someone asked about. So someone said they had children before finding out about the condition, and asked about whether testing and family planning can be funded under Medicare. So the testing, there is Medicare funded testing for PKD. The family planning part is a bit more complex. So there are Medicare item numbers for pre-implantation genetic testing, but they don't cover the whole cost. So there is still an out-of-pocket cost for that if that was something that you wanted to pursue, if a person wanted to pursue. Prenatal diagnosis can be accessed both through the private and the public sector, and it depends on whether you go through the private or the public sector, whether you're going to wind up paying for that. Again, similarly, there are private and public options for accessing genetic counselling, and there are no Medicare item numbers for genetic counselling. That's something that the Human Genetics Society of Australasia has been pushing for quite some time, but that's been quite challenging to get up. So again, that would be either through a public service, often with quite a long waiting time, unfortunately, or via a private service. Okay, can I speculate on the possibility of CRISPR-Cas9 and AI creating a cure for AD-PKD? Okay, so I'll dispense with the AI first. I'm not sure that AI is going to make a lot of difference in this space in the near future. But I am also someone who couldn't see why anyone would ever want an iPad, and there are about 7 tablets in my house now, so I may not be the best person to ask about the pace of future technological change, but certainly right now that wouldn't be a focus, I don't think. As for CRISPR-Cas9, so I guess this comes under the category of gene therapy. And gene therapy is the idea of treating a genetic condition by directly addressing the genetic change in the relevant part of the person, in this case, the kidneys, particularly. And there are different types of gene therapy. So there's gene therapy where you replace a missing gene, and there are various ways of doing that. And then the idea of using, so CRISPR-Cas9, for those who may not be familiar with it, is a method that allows us to edit genetic material. So to cut out a little stretch of DNA and then replace it with a different stretch of DNA. I have to confess I'm not up to date with efforts. I'm sure there are people working on gene therapy for PKD, because it's such an important condition that affects so many people, but I don't know where it's up to. I would think that possibly CRISPR-Cas9 would not be the first choice, because it's much more complex, much more difficult, and if I remember rightly, the genetic mechanism for PKD is one where you've got a faulty copy of the gene, where you'd be more interested in replacing it rather than changing it. And so I don't think that's the method that would be most likely to be used. At the moment, as far as I know, all of the gene therapies that are approved for use in humans involve adding in a gene product that's missing. And the problem with CRISPR is that any way that you give it, there's a risk that it might produce changes somewhere other than where you're targeting it. And so people worry about potential negative effects. For example, and I'm not saying this is likely, but a thing that people worry about is the possibility of inducing a change that might eventually lead to cancer. So there's quite a lot of caution about the idea of using CRISPR-Cas9 in a living person, but that's not to say it'll never happen. And it's certainly something that people are working on. So it's not out of the question, but I don't think that particular approach is close. And I'm not sure it would be the way that gene therapy would be done for BKD in any case.
Thank you. Time for maybe 1 or 2 more.
Sure. Okay. When can PKD be detected in a carrier, and when can it be traced to offspring? Well, if someone has PKD, then they're eligible to get tested. There is Medicare funded testing, and it's really about arranging to see someone about getting the test. I mean, there's no particular time. I'm not certain I'm understanding the question, but there isn't a particular time that you need to wait or whatever. It's more about just accessing the test. There's a question about which IVF clinics offer PGT for PKD in Victoria, and I'm afraid I'm based in New South Wales, and I'm not really familiar with I mean, I know of a couple of the clinics, but I think there are several clinics, but you'd really have to, I think, look at their websites. Any clinic that's offering PGT is likely to be able to do this. Even if they don't specifically mention PKD on their websites, if they talk about PGD or PGT, then the chances are good that they would be able to test for PKD. Okay, and then there's a question from a healthcare practitioner about counselling patients about IVF and genetic detection of healthy embryos, and I'm afraid that feels like too big a topic to tack on at the end, but I'd be very happy to be emailed and maybe have a chat with that person if they're on the call.
Thank you. Yeah, that sounds great. If there are any burning questions, then please feel free to email me at manager@pkdaustralia.org or email Professor Edwin. And his email, well, you could say it now, but it is publicly available.
Yeah, you can Google me.
Yes, just Google him. All right, well then we'll finish up there, and I just wanted to say thank you for taking some very complicated genetic science and presenting it to us in a very understandable way, and even by way of a history lesson there. It was extremely fascinating. And thank you for giving us another tool in our belt so that we are equipped to make those informed choices, particularly for those of us in our community with AD or AR PKD and perhaps wanting children. So thank you to everybody as well for attending. And on behalf of the Board of PKD Australia, I would just like to sincerely thank Professor Edwin for his time, taking time out of an evening and sharing your expertise and your experience. And with that, I would like to wish you all a good night. Thank you for coming, and we'll see you at our next webinar.
Cheerio.